Hello everyone, welcome to Physiology. Today I am going to explain intervertebral disc prolapse, most commonly called as ivdp or disc herniation or pivd, that is prolapsed intervertebral disc prolapse. So it's also known as disc herniation or prolapsed intervertebral disc prolapse, and it's nothing and also called as herniated nucleus pulposus. The anatomy behind this is, so we have our spine, right? In spine we have different vertebra: cervical, lumbar, cervical, lumbar, thoracic and sacral and all. So between each vertebral body we will be having a vertebral disc, that is intervertebral disc. So anatomy, coming to the anatomy part, so between each vertebrae we have intervertebral discs. There are totally 23 intervertebral discs. So in the cervical region we have 6 intervertebral discs, in thoracic we have 12 intervertebral discs, and in lumbar region we have 5 intervertebral discs. So in cervical we have 7 vertebra, but between atlantoaxial joint we don't have any vertebral discs. Okay, disc. Next, the vertebral body which is there is covered by a thin end plate. So here I have shown you this green color one. I don't know if it's clear or not. So here this green color one is nothing but our end plate, and then the anterior and lateral vertebral bodies and vertebral discs are bounded firmly by anterior longitudinal ligament. The vertebral body along with the vertebral discs is bounded anterolaterally by the anterior longitudinal ligament. So most of the time there is no anterior disc prolapse, and posteriorly it's by posterior longitudinal ligament. This anterior longitudinal ligament is very strong ligament, whereas compared to posterior longitudinal ligament it's slightly weak. So mostly we'll be seeing posterior disc prolapse or posterior disc herniation. Next, intervertebral disc in adults is avascular. So there is no vascular supply or blood supply. So how does the contents get their nutrition? So they get their nutrition by diffusion. How does this diffusion occur? It occurs by the weight bearing and movement. So whenever we move our body, whenever we lift a weight from the ground, so there will be the diffusion taking place within the IVD. Thus there will be spread of the nutrients in the intervertebral discs. So intervertebral disc consists of two parts, that is the end plate and the disc. So end plate is thin one, and disc is having nucleus pulposus which is centrally located, and annulus fibrosus which is peripherally located. Centrally, here this is a cross sectional area. So in center we have nucleus pulposus, surrounding the blue color one is called annulus fibrosus. So this nucleus pulposus is made up of collagen, and whereas annulus fibrosus is made up of fibrocartilaginous structure. Thus the annulus fibrosus is a strong one and nucleus pulposus is a weak one. So, and here this is a physiology where the intervertebral disc along with spine helps in spine mobility as well as shock absorber. The disc acts as a spine mobility and shock absorber. So all the spines degenerate with the age, right? So as the age prolongs, as the age gets increased, our disc degeneration as well as the spine degeneration also starts. So with age, water content in the disc also decreases. So loss of disc. So when there is a loss of disc, our vertebral body, so our vertebral body which is a bony prominence will be reacting to the abnormal pressure. So before, when the disc is normal, our disc used to take the pressure, but here our vertebral body takes the pressure, so abnormal pressure force will be developed. This abnormal pressure force which is taken by the vertebral body will be resulting in the formation of hypertrophic bone. So this hypertrophic bone in the surface is, how does it revealed? It will be revealed as a sclerosis or osteophyte formation. And all again, osteophyte formation, if there is an osteophyte formation, again the disc will be having a problem. So again there will be a compression of the nerves and all. So disc degenerative process is divided into 3 stages. In the next slide I'll show you this. The degenerative process of the disc involves 3 stages. First stage is stage of dysfunction. So this stage of dysfunction occurs in 15 to 45 years of age. Here there will be circumferential and radial tears which are seen in the annulus pulposus and also there will be localized synovitis of the facet joint. So here there is a radial or circumferential tear of the annulus fibrosus, and also there is a localized synovitis of the fasciate joint. And next, in stage of instability that will be carried out in 35 to 70 years, there will be an internal disturbance or disruption of the disc and progressive disc resorption. So here the disc will be resorpted and degenerative facet joints which will be having a lax capsule. So in the third stage, the stage of stabilization, it will be the third stage which will be above the 60 years. So in the stage of stabilization, there will be progressive development of the hypertrophic bone. So in the previous slide also I have told you about the hypertrophic bone. So here there will be progressive development of the hypertrophic bone, and also the about the disc facet and the which is leading to the segmental stiffness and ankylosing. So there will be a progressively the disc will be increased in size, progressively the vertebra will be increased in size, and the facet joints etc will be increased. So there will be fusion of the bones, you can tell that. So now so in stage 1 and 2 we'll be seeing disc herniation, but in late of the stage of instability and early stage of stabilization we see spinal stenosis. Our last video is that only, lumbar canal stenosis. So there, so stage of instability and stage of stabilization, in this age, that is around 35 to 60 years of age, we'll be seeing this spinal stenosis. So usually that spinal stenosis occurs at the 40 years of age. So here classification of prolapsed intervertebral disc. So here classification, you can tell this as stages also. So first one we see a bulge. So here we see a bulge, and sorry, excuse my diagrams, I'm not a good artist. Okay, so prolapsed disc. So here bulge disc, there will be a eccentric accumulation of the nucleus with a slight deformity of the annulus. So eccentrically the nucleus will be enlarged or expanded, and also there will be slight deformity of the annulus. So here you can see the slight deformity of the annulus. In second stage, that is the prolapsed disc or protrusion. So one of the in this eccentric nucleus produces defined deformity. Here you can see the deformity of the annulus. And next, in the stage 3, that is the extruded disc. In extruded disc or extrusion, we see that the disc comes out into the canal. So the disc that is there, that is coming out into the canal. I should draw more a bit. So the disc will be entering into the canal and impinges the adjacent nerve root. And last stage is, that is the sequestration. There is no contact between the mother or the parent disc as well as the this new disc. So here the nucleus the nuclear matter has been separated from the disc itself and potentially migrates. There is no contact with the disc. Okay, so now coming to the etiology. In etiology, there is a risk factors. What are the risk factors? Who are more prone to this intervertebral disc prolapses? So people who do weightlifting, and people who use mechanical tools and motor vehicles, cigarette smokers, tobacco consumers, anxiety patients, depression patients, and people who usually have this stressful jobs like doctors, police, teachers, waiters, who need to stand for prolonged time and all. And also there will be job that requires heavy and repetitive weightlifting activities, and women with more number of pregnancies. So this all comes under the, and also if you don't have a good posture, this all comes under the risk factors that you are at a very high risk of getting this intervertebral disc prolapsing. And next, definite cause. What is the actual cause? Is that, so there will be a degenerative changes. So what do you mean by degenerative changes? That suppose, assume that the in the previous slide I have said you that the disc according to the age, as per the age increases, the disc also will be decreased. So when there is a degeneration of the disc, so the disc will be susceptible to trauma. So when there is a sudden trauma, or when you fall on the buttocks, and these all many reasons, else more reasons, so they help they result in the rupturing of the that results in the rupturing of the posterior fibers of the annulus. I have said you in the previous slide that the posterior fibers of the annulus are very weak, so that results in the degenerative changes. And next, pregnancy. Repetitive pregnancies will be leading to lordosis, and that will be in turn resulting in the disc prolapse. And others like weightlifting, fall on the buttocks, direct trauma to the back, twisting movements, occupation which involves more flexion and lifting motions, and also ruptured with degenerative diseases. So next, clinical features. Now we are going to the clinical features. Clinical features where we see the low backache. So I've forgot to tell you a point. So this intervertebral disc prolapse can occur in any region, but mainly we see it in the cervical and lumbar region. In cervical region, why do we see intervertebral disc prolapse? Is because the highest mobility rate of the cervical spine causes the intervertebral disc prolapse in the cervical region. What about the lumbar region then? Lumbar region only is more commonly seen than that of the cervical region. So in the lumbar region, our whole body weight is bared by the lumbar spine and lumbar vertebrae. So lumbar region is more prone to the intervertebral disc prolapse. So here mostly the clinical features include low backache. The main cause for main or the like most recurrent cause for low backache is our intervertebral disc. So pain is commonly seen in second decade. So herniation, disc diseases, etc. are seen in the third and fourth decade. So you are not supposed to tell that in second decade if you are having a low backache, you're not supposed to tell that it's IVDP. Until and unless you are having some problem with your disc, you're not supposed to tell that it's an IVDP. So in the third and fourth decade itself, we get this herniation disc diseases. And in the lumbar disc herniation, there will be repetitive low backache that will be radiating to your buttocks, and this pain will be reduced when you take a rest. And this is a hallmark sign for the lumbar intervertebral disc prolapse. And next, pain increases when you sit, cough or sneeze, but pain decreases when you take rest or when you are assuming a semi-floor position. And next, nerve root compression. So first sign is a low backache and second one is nerve root compression. Which nerve root is mostly compressed? So the L4 and L5 region is mostly compressed. 95% of the disc prolapse are seen in the L4 L5 region. So here the L5 nerve is compressed. So others, that is the L3 L4 region, L4 nerve is compressed. L5 S1 region, S1 nerve is compressed. According to the L5 L4 and S1, their distribution, the dermatomes and myotomes will be affected. Radiculopathy. When the disc, I have said you here, in the extrusion there will be a defined deformity, and this nucleus pulposus will be coming out of that, and it will be impinging the nerve. So here the pain along the sciatic nerve distribution we see, which is called as sciatica. And next, others include loss of others. What do we see here? Loss of lordosis, then compensated tilt we see, and then decreased spine mobility we see, and diffused tenderness in the lumbosacral region we see. So now we are going to see the tests which are based on the stretching of the sciatic nerve. So there are n number of tests for IVDP. In the next video, I will be telling about the number of tests and the symptoms and signs that are involved according to the level of disc herniation. So here on a vague the video length is becoming a bit more. So I'm just making it short. So forward bending we do it to touch the toes. And next, slump test. You know all the slump test where we sit on a chair and we just like forward bend our neck and the neck and back, and then we alternatively raise our both the legs. So next, SLRT, that is straight leg raise test, which will be positive at 30 to 70 degrees of elevation, which will be positive for the sciatic nerve stretch or sciatica. So reverse SLRT is a test for femoral nerve, where we see the upper lumbar disc herniation. So most commonly we see in the, I have said you just now, L3, L4, L5, S1. So in these regions we see the lumbar disc, there's a lower lumbar disc herniation, but in sometimes L1, L2 also may be having a disc herniation, which is positive by the reverse SLRT. Okay, next, investigations. In investigations we see X-ray. So X-ray is not that reliable, but here why do we take an X-ray is just to identify the disc space, that is the space between the vertebra, and also are there any osteophyte formation, is there any old fractures, or is there any TB spine. So to rule out that, we take an X-ray of the lumbar spine, which has in three views, like anterior and lateral views of lumbosacral junction. And next we go for myelography. Myelography where we inject a myodal this injection into the canal, that is our spinal canal, and there will be a myelography taken, so that is there any involvement of the nerve compression or that we will be seeing there. And MRI, in MRI it's a basic non-invasive method where it's a, like we can easily tell about the disc herniation and all. And CT, that is a computerized tomography. And then discography, here we inject a like glue or dye, that is we inject a dye that's its name is xylocyan. So xylocyan is a injection that we give to the directly to the disc, so that we see the disc properly when you take an imaging study. And next, other tests that include bone scans, and then EMG, lab tests, and injection studies, etc. So here treatment, coming to the treatment, we do conservative and surgical management. Conservative is nothing but basic bed rest is more than enough for a IVDP patient. Along with bed rest, even though if he is taking a bed rest and it's not reducing, we give him ice packs and all. And mostly we'll tell him not to do bending activities and all. And next, surgery, we do surgery we'll be doing this laminectomy, and next fenestration, next endoscopic lumbar discectomy, and microscopic lumbar discectomy, hemi-laminectomy, and all. These are the surgical procedures that we do for intervertebral disc prolapse. So this intervertebral disc prolapse is a very big topic where we need to understand each and every like small point even. So my video length is very like it has become a very big one, so I have made it as short as I can. So any doubts, please comment down, so I'll try to explain it more clearly. Like I'll make few more parts of this video, and in the next video we'll be learning about more in detail about the different types of tests that we do for IVDP, and then treatment in detail. So what is the physiotherapy management and all, we'll be learning in the next video. And till that time, please stay tuned to my channel, like, subscribe, and share my channel. Thank you.